Welcome to Health Frontiers, where we explore the uncharted territories of well-being. I am Dr. Robert Lahita, also known as Dr. Bob. With over 50 years in rheumatology and immunology and 17 years as the chair of medicine at 3 major medical centers, my mission is to simplify complex medical issues for you. Join me as we uncover the latest breakthroughs in health, answer your pressing questions, and discuss nutrition and holistic living. This podcast is all about empowering you with the knowledge and tools to manage your health effectively. Let's embark on this transformative journey together. Well, hello there. I'm Dr. Bob, and as you know, we deal with patient questions at the beginning of this show. And patients are encouraged to write to our special email, which is going to be given during the show or at the end of the show. First, I'd like to address a few questions from patients. Among the myriads of questions I receive, many revolve around the topic of hearing loss. One of the most pressing issues is the use of iPods by young people, a trend continuing to cause a rise in hearing loss among adults and teenagers. Recently, an editor from a New Jersey newspaper called me and reached out and said, "Can you tell us a little bit about hearing loss and what it's all about and why is it on the rise?" So really, let's talk about the causes of hearing loss. Many cases of hearing loss in children that produce deafness result from neurodevelopmental issues in the mother's womb. That's not what we're going to talk about in this part of the show. But there are 2 kinds of hereditary hearing loss, genetic and something called epigenetic. Regular heredity as a cause of deafness is called congenital or inherited hearing loss. Environmental influence is what we're interested in here, and that causes hearing loss, and that is an environmental-induced hearing loss, which has another name. It's called an epigenetic hearing loss. Loud music, or even an autoimmune diseases affect the cells within the ear, the tiny hairs that allow us to hear. The otic hairs, and that's what they're called, are in the ear and connect to the brain, as do the nerves of many senses, such as smell, for example. But with the nose, it's called the olfactory nerve. In the ear, we call it an otic nerve. So a question came in from a listener who said, "My son uses headphones because we complained about his loud music. Would that cause deafness?" And the interesting aspect is, yes, it can cause deafness. It's crucial to use headphones selectively. Musicians from the old days, like the 1960s and 70s, many of them still with us, could stand before a speaker blasting loud music throughout their show. It still happens today, and many of them are totally or partially deaf. Musicians develop a deafness called a deafness from a musician's notch. And a doctor or a person who measures hearing loss will be able to identify the musician's notch. This hearing loss is very, very common. When your son uses headphones or your daughter uses headphones or iPods and listens to loud music, he or she risks losing their hearing as they age. Now, to prevent this, it's best to limit the volume of the iPod or headphones, and I use what's called the 60-60 rule. 60% intensity of the music, and listen to the music for only 60 minutes a day. The 60-60 rule is simple and effective and a way to protect your hearing, as people know it. Hearing is very important. A clue to the beginning of hearing loss is in crowds or in a restaurant or in a ball game where you don't hear people beside you talking and you don't hear consonants, which is the hard D's or C's when someone is speaking or perhaps asking you a question. So noise-canceling headphones are a great idea, and that should be used by young people. And most young people block other people from their music, such as their parents or in some cases their friends, and they listen to music very loudly. But the noise-canceling headphones can block out external noise and allow a child to listen to the music at a much lower volume. So what we're saying is they clearly turn the volume up because there's a lot of other noise around. Parents talking, their brothers or sisters, or in fact, external ambient noise from, say, traffic in the street or from people closing or opening doors. A famous company sold these noise-canceling headphones for flights, air flights in particular, because of the roar of the engines. And people complained that the passengers weren't able to hear the music that was on their seat rests and the audio from films that they were watching. They couldn't hear them. So they had these noise-canceling earphones. A lot of the airlines became smart and actually offer their own noise-canceling earphones so that you could watch a seatback movie or you could listen to music without raising the volume. So someone else said, what are the other ways to decrease the chances of hearing loss as we age? Well, other suggestions are to take breaks from listening to loud music so that you avoid long-term periods of use. OSHA requires that people who work with jackhammers or drills in their daily work wear earphones to prevent hearing loss. You want to avoid listening to high volumes because all of that can certainly damage your hearing. You want to use noise cancellation headphones in a loud environment. And some of the examples I give are with NASCAR races. Now, many of you have never been to a NASCAR race, but if you have gone to a NASCAR race, you know how loud the engines are. And most of the veterans that go to these races wear noise-canceling earphones. They're headsets that allow them to listen to the announcer talking about the race itself, but they don't have problems with the loud noise of the engines. Another example is a wedding reception, where it seems these days the music is cranked up so loud, especially for older folks who are in the room celebrating a wedding of younger people, they can't hear a thing. And they possibly have hearing loss to begin with, and this only enhances it. So people should take sound breaks, leave the room, go out and talk to your relatives or talk to somebody on your cell phone, but not in the same place where the loud music is. So the last question is, should everybody have hearing checks? And this is from a young man who's local. And I am going to say that, yes, most people lose some hearing as they age. And as I mentioned, if you're a member of a rock band or you work or you're a laborer who doesn't use earphones and you have a problem hearing what other family members or other people are saying, and that means you continuously say, what, when someone speaks. If that is the case, you should have testing of your hearing. And how is that done? Through an audiologist. An audiologist is not a medical doctor necessarily, but it is somebody who's very, very attuned to measuring your hearing in great detail. An audiologist, and then there are otorhinolaryngologists, better known as an ear, nose, and throat doctor, who can also test your hearing. And the hearing test will result in a pattern, and the doctor, the audiologist, or the physician can tell you whether you are going deaf or whether you have a hearing deficit. So last thing is the same person asking, I don't want to wear unsightly hearing aids. What do I do? Well, we've come a long way with hearing aids. This is not your grandfather's bulky ear trumpet anymore. This is something that is very, very typically useful with Bluetooth. Bluetooth can really allow you to have a conversation with your mobile phone privately. You'll hear with your hearing aids everything that's coming out of your phone. You can hear music, and you can hear, you can even watch a movie on your iPhone, and it'll come across in your hearing aids. These are high tech, And a lot of these high-tech hearing aids are wrapped into artificial intelligence, which can correct your hearing for the condition. For example, if you're at a theater, at a ball game, or in a restaurant, AI will provide you with the right tenor of hearing so that you can hear everyone around you and you will no longer have a problem hearing. Your hearing loss may not be corrected, but it will be corrected with the hearing aid, the hearing assistant. So that's really all that I can recommend for this part of the show on hearing and hearing loss. Remember the 60-60 rule, 60% intensity for 60 minutes every day for your young person with iPods. And now we're going to bring in our guest. Well, we're very happy today to have with us a distinguished guest and good friend, Dr. Stephen Dane. Dr. Dane is a board-certified neurologist, and he is still at Mount Sinai Medical Center in New York City. He was trained at St. Vincent's Hospital in Manhattan, the former St. Vincent's Hospital, where yours truly was chief of rheumatology. But very, very important, he is a New Jersey Athletic Control Board member, and he is a very, very effective and talented neurologist. So we've asked Dr. Dane to come in today to talk about a very important topic called neuropathy. Now, most of you out there have heard of neuropathy, but I'm sure you have no idea of what it is or even the history of it, which is quite remarkable, actually. So, Steve, welcome. Welcome to the show.
Thank you very much.
And the first thing is, could you define neuropathy for our viewers?
Okay, so neuropathy is a problem with the nervous system outside of the central nervous system. The neurologists discuss the anatomy of the nervous system as being central or peripheral. Central nervous system, our brain, our spinal cord.
Mm-hmm.
Peripheral, coming from the Greek word to be around, is everything else outside of it.
Mm-hmm.
So, what brings someone to start thinking that they have neuropathy is that tingling, that numbness, or even that burning that they experience in their arms, hands, feet, legs.
Yes.
And that's what brings people in to get screened.
Yes, we see it with the immune disorders where there are many patients who come in with burning feet and burning hands. And that's a tip-off to the doctor to say, this is nerve pain.
The first descriptions in the literature, my God, they go back like to the year 1200 BC. There was a report years ago in Archives of Neurology that there was a Hittite king who could not attend the wedding of a daughter because of his burning feet. No doubt it sounded like diabetic neuropathy.
Yes.
So, but throughout the medical literature, it's been described continuously. Through the 19th century, the 3 T's of peripheral nerve problems: tuberculosis, syphilitic infections and effects on the nervous system, tabes dorsalis, and then finally, traumatic injuries, causalgia.
And, the tabes dorsalis for the viewers is definitely associated and is one of the 3 T's with syphilis. And it's the way people walk that have syphilis. It's very unusual.
It was the way that they would walk and flop. It filled 19th century literature descriptions, and even in the 20th century, it's described. And then causalgia, initially being described during the Spanish campaigns of the 1850s, and then by the time the American Civil War came around, American neurologists, especially someone named Weir Mitchell, who was at the University of Pennsylvania, described on battlefield injuries this type of lanciating nerve pain that would develop after people had been successfully rescued from the battlefield.
Mm.
The traumatic nerve injuries owe themselves to 1847, right?
Right.
The development of use of chloroform for anesthesia,
Yes.
and Semmelweis's paper on that you should wash your hands before you do surgery.
Absolutely. Absolutely. What did people do with neuropathy before the advent of anesthesia?
Opiates, probably.
Opiates, morphine,
tinctures of opiates.
laudanum.
Laudanum and stuff like that was being used. And it's still, for better or for worse, it's still one of the things that pain management doctors still use in treatment in very intractable cases.
Right.
We try not to. There's many other things that we're doing now where you basically trying to modulate the electrical activity of the peripheral nervous system and the GABA pathways, a chemical within the central nervous system.
Right. Right.
We've been using, probably since the 1950s, various types of antidepressants, various types of anti-epilepsy drugs in trying to modulate and treat.
Do they work?
Neuropathy. Yes. Do they work? They work better than nothing. They work better than the opiates probably did, with less side effect. The introduction of phenytoin in the 1930s showed that there was a pathway for the treatment of peripheral nerve problems. And every group of anti-epileptic drugs that gets introduced for the treatment of epilepsy, invariably, there's an attempt to use it for neuropathy and pain syndromes.
Right. And those of you who are watching realize if you have neuropathy, that some of the medications that are prescribed have limited effectiveness. So I think it's important to know, as Dr. Dane points out, that oftentimes the doctor has to try many agents before you have successful removal of that pain. And then the pain management person, I hope, doesn't go right to opiates.
No, they don't. I mean, you're going to basically cycle someone through a planned program of, tricyclics maybe, then anticonvulsants, and then calcium channel blockers and things of that sort. But this is basically what we call now neuromodulation. I mean, the most important thing as a neurologist when I'm seeing a neuropathy patient, I think, is to ask, what's the pattern? This symptom, this unpleasant state has been rattling around in your brain as a patient probably for weeks or months.
Right.
And, you walk into the room with the neurologist and it's I think I have neuropathy. Well, you know what? Let's talk about what you're experiencing. No, I think I have neuropathy. No. Let's talk about the symptoms first.
Right.
Let's talk about what provokes it. Let's talk about its quality. What's the pattern of it? And then let's start to give diagnoses.
Good.
Very
systematic way of doing things.
Right. The neuropathy workup, will involve a physical exam. Doctor should ideally examine your hands. They should examine your feet and legs. If the doctor is not asking you to take off your shoes and socks to examine you for neuropathy, maybe that's not the doctor for you.
That's very well put.
Okay.
Very well put. Well, fortunately, I know most neurologists and most rheumatologists do examine all four extremities, but I'm not so sure the family doctors really get into that.
They may not, and it may be a matter of time, but if you have neuropathy and you're going to go see your doctor, before they walk into the room, take off your shoes and socks.
Right.
It will remind them of what they should be doing.
Exactly.
Okay?
Right.
Because in the end, it's pattern recognition.
Right.
The neuropathies, does it affect the distal hands and feet? Is it just in your feet? Is it across the trunk of your body? is it in your face?
Mm-hmm.
You may see someone convinced, oh, I have neuropathy. I've got numbness in my feet. And then they're talking to you about an MRI of your neck.
Mm-hmm.
Because the nervous system has a limited repertoire in which to express abnormal pathology. I mean, you're a rheumatologist, right?
Yes.
Pain is the common pathway for joint disease, right?
Yes, that's correct.
Plus or minus, let's say, deformation of the joint that's visible to you on a physical exam or on an x-ray.
Absolutely. Very true. But you can't see neuropathy with an x-ray.
Right.
So
You're not going to see it with an x-ray, and you're not even going to really see it with an MRI.
mm-hmm.
What the questions that those studies will answer are, is there anything structural that mimics that neuropathy? I mean, the hallmark of neuropathy testing, after you have a blood workup, that should include evaluations for things like diabetes, thyroid problems, vitamin deficiencies, infectious causes, is a test called an EMG.
Right.
Which is an electrical test of muscle and nerve designed to figure out where nerves may be pinched or damaged.
Right. Tell us a little bit about an EMG, because patients really don't have much of an idea of what an EMG really is all about. They just know that it hurts.
Okay. Well, so a neuropathy essentially comes in two flavors. Neurologists describe it as either axonal, they use the word axonal,
Mm-hmm.
or they use the word demyelinating. So let's kind of break that down.
Right.
Axon is a part of a cell body. So think of a long, stringy structure, okay? And this is the arm axon
Mm-hmm.
of a cell
Right.
that reaches from the spine down to the extremity.
And that's a nerve cell.
That's a nerve cell. The axons get woven together into, let's say, a cable, right?
Mm-hmm.
A wiring harness. But the entire wiring harness is actually covered in a fatty substance. This fatty substance, called myelin, helps insulate it, conducts better. So the problem in a neuropathy is either going to be a drop-off in axon cell bodies or a loss of myelin. And the EMG gives you some guidance about
Now,
that.
explain for our viewers what myelin is.
Myelin is a fat. It's a good fat.
Mm-hmm.
You don't want to lose your myelin.
Right.
It is built up in the human central nervous system.
Mm-hmm.
Takes, 2.5 you basically myelinate fully by the age of 22 or something like that,
Mm-hmm.
which is why we treat decisions made by young people differently than decisions by older people, because nervous system is still under construction. When a neurologist sees an infant, I just see a big sign that says nervous system under construction.
Very
Okay.
interesting approach.
So-
I mean, I never really thought of that.
So, that nervous system is still myelinating and will do so till you're probably in your early 20s. Okay. Now, you myelinate in the central nervous system and you myelinate in the peripheral nervous system.
Right.
Okay.
Now, I always explain to patients over the years that myelin is sort of the insulation around the nerve. Is that an accurate description?
That's a good way to think about it,
Yeah.
because what it does is that it speeds up the electrical signaling process.
Mm-hmm.
A unmyelinated nerve conducts in a speed of inches per minute.
Mm-hmm.
A myelinated nerve gives conduction times in feet per minute. It's much faster, much more efficient. It's what lets a large multicellular organism stand up and walk around.
Right. That's what allows us to walk
Yeah.
and know where we're going and keep our balance.
Right. So the myelin is part of that outer wrapping. Now, the EMG is an electrical test which gives characteristic patterns for loss of myelin versus loss of axons. So at least it points you in a correct direction. Generally, as a matter of course, if you have an axonal neuropathy, we tend to leave the investigation at that point.
Right.
If you have a demyelinating neuropathy, that beggars a little bit more investigation. It's a little more uncommon, a little rarer. And sometimes we'll do actually biopsy.
Of the nerve itself.
Of a nerve itself. Usually, you can do a biopsy of a larger sensory nerve. For instance, a nerve at the back of your calf that you may not miss. A little numbness at the back of the calf isn't going to change much.
Right.
Or even looking at very small nerve fibers in the skin in a small punch biopsy.
Right.
But that's certainly going to be part of your investigation.
Right.
Even genetic conditions that cause neuropathy may not become apparent until you're, could be in your 20s or 30s. They can be slow and progressive.
Right. Very interesting. Very interesting. Because you bring up a lot of points. This small fiber neuropathy with biopsy, we as physicians, as rheumatologists, immunologists, and general internists are not fully aware of the fact that when you biopsy and you see this small fiber neuropathy, you're looking for myelinated nerves?
Well, there you're looking for, these are not myelinated in small fiber.
Right.
This is an axonal dropout. So let's say someone has a normal EMG.
Right.
And they still have complaints.
Complaints being
Of
pain or numbness?
Burning, numbness. Sometimes you'll say, we're going to try to do we're going to look for a small fiber neuropathy now.
Yes.
Not to forget that people can come to you for burning in their feet.
Right.
And you kind of examine them and you say, I think we should image your neck.
Yes. Okay.
I mean, because what that examiner's picked up on exam is some suggestion that it's not a peripheral nerve problem.
Right.
That it's really a problem within the central nervous system.
Central nervous system problem. Very important. Very important. We have, and I'm sure you as the listeners and viewers realize that there are advertisements on the national media now for the treatment of something called CIDP, chronic inflammatory demyelinating neuropathy.
Yes.
And a lot of my patients have said, what the heck is CIDP? Of course, my patients that have CIDP, which is an exquisitely sensitive and very painful condition, which we treat with a variety of immunoglobulins, for example, like intravenous immunoglobulin and stuff like that. If you have CIDP, you'd know what I'm talking about. But this is a big issue.
I remember when we had, you remember also when you had the blood bank technician on call to do plasmapheresis.
Exactly.
CIDP is in the family or on the spectrum of demyelinating neuropathies.
Right.
In which the immune system turns on itself.
Right.
A fulminant course of a demyelinating neuropathy has the name of Guillain-Barré syndrome.
Right. Oh, Guillain-Barré is very important to talk about in a second once we get past CIDP because of all the patients out there with COVID infections that developed Guillain-Barré going forward after their infection. And many people, and I'm sure we're going to get into this, talk about it after the vaccine. I don't know how real that is, but I'm hearing it from a number of patients.
Well, there's been a recognition that autoimmune inflammatory demyelinating neuropathies were associated with a higher risk of vaccination.
Mm-hmm.
To the extent that I guess in the 1980s, and vaccine manufacturers, basically went to the federal government and said, listen, we need some relief from the liability because it is a social good to vaccinate people.
Yes.
On the other hand, there are people who got hurt.
Yes.
So the federal government created a no-fault program for vaccine manufacturers to participate in.
I wasn't aware of that. That's pretty interesting.
It's a federal program. It's overseen by a federal master. You submit you have to make a claim within a certain number of, show a time frame linked to a vaccination. It is supervised in the federal court system, but it's basically done through special masters and then an arbitration process.
Mm-hmm.
It doesn't take place in the regular federal court system. The idea was that it would offer some backstop assurance to the general public.
Mm-hmm. Do you see more Guillain-Barré, now that we're on that topic, with the COVID vaccines?
I it's so hard to talk from personal experience.
Right.
First of all, you're talking about a entity, Guillain-Barré, which has an occurrence in the general population of 100,000 people as a single-digit occurrence.
Right. Wow.
I mean,
yeah,
it's not
common.
It's not common.
So
you have to, when you're in training, you're in a large hospital system that like sweeps cases in, and you see, as a neurology resident, you see your 10 cases of Guillain-Barré during your residency.
Right. Yes.
Afterwards in practice, I've seen a couple cases walk into the office. It after COVID, I mean, you would be in a much better position, I think, to talk about it.
Yes.
Because it's a more, especially with CIDP, it's a more chronic condition which people are going to sort through.
And very painful. And a lot of my patients have used Guillain-Barré as an excuse not to be vaccinated, which is not a good thing because as Dr. Dane says, it's very, very rare, but it does occur. And we have to be prepared for it. Most doctors can recognize Guillain-Barré, which is an ascending, can I describe the clinical?
It's an ascending paralysis, usually with, most of the time, very minimal sensory symptoms, but it's a paralysis that will occur over a matter of hours to days, and the marked part of it is that when you examine someone with this condition, when you check their reflexes, take that little triangular hammer and bang on their arm and expect to see a little jerk, they've lost their reflexes.
Okay.
It is considered urgent because we hospitalize people because a certain number of people, this ascending motor paralysis will involve respiratory muscles.
Mm-hmm.
As the use of immune suppression will change the course, but you have to be prepared to provide respiratory support.
Right. So that's why a lot of patients with Guillain-Barré are in the intensive care unit.
They're admitted to the hospital, and if they've got a Guillain-Barré diagnosis, they are sitting in a unit under observation.
Right.
Because they can crash. I mean, crash is the phrase we use for someone whose condition takes a sudden turn in a matter of minutes.
Right.
So, but this is a pretty rare occurrence.
Right.
Yes, the risk of being injured in an airline crash is infinitely higher if you get on an airplane than if you travel by car.
Very, very interesting. And very interesting that you say that. So for all those people out there that say, I'm not going to be vaccinated because of Guillain-Barré.
It's relative risk.
Yeah. Relative risk is very, very low.
Relative risk is really, really low. Yeah, that's not zero,
Right. Well,
but the alternatives are not pretty.
right. While we're talking about myelin sheaths, which is, again, the insulation around the nerves, Dr. Dane mentioned CIDP as being an autoimmune attack on the nerves, and we treat that. We treat that in rheumatology and in neurology and in immunology. But I'm wondering about if you would say anything about multiple sclerosis, which is a disease that is a little bit more common, very autoimmune, and which involves demyelination.
All right. So, we've gone from peripheral neuropathies now
Right.
to demyelination within the central nervous system.
Okay.
So multiple sclerosis was a disease separated in which neurological episodes are separated in time
Mm-hmm.
and in localization within the nervous system.
Right.
The true incidence of multiple sclerosis is actually pretty high.
Yeah.
Because we've developed imaging technologies that can look at myelin in the brain, namely MRI,
Mm-hmm.
even in the absence of symptoms,
Mm-hmm.
in which we see demyelination. It's only when you sit down and, say to the person, tell me, have you ever had something where you woke up one morning and your vision was cloudy? Maybe for a day or two,
Mm-hmm.
out of one eye. Yeah, I thought I caught a cold or something. Okay.
Yeah.
You sit down and kind of sit, did you ever have numbness in your arm I had numbness in my arm for like a week. And I just kind of worked it out, figured I just sprained something.
Oh, this is central nervous system.
This is central, but these are central nervous system
the
episodes.
peripheral nerves are not demyelinated in multiple sclerosis. Very important.
Yeah, they're not. The peripheral nerves are not. This is a central nervous system condition.
Right.
And, at one point, we had very minimal treatments available for it. Now we have a whole host of immune modulators that change not only shorten an episode of multiple sclerosis, but will help alter the lifetime trajectory.
Right.
Making it necessary to identify those people. I mean, I still remember a debate in the medical literature in the 80s, or when I was a resident, like, should we tell people about this diagnosis?
Yes.
I mean, because what are we going to do for it? Why should we worry them? And of course, the issue for telling a patient about a diagnosis, even if you don't have a treatment then, is maybe there'll be a treatment in a year or 2 years.
Right.
So that person has to know.
Yes. Very important point. Very important ethical point.
Yeah.
To let people know about their illness, especially when we detect a problem where they may have no symptoms whatsoever. Right. And I'm very interested in MS because of its autoimmune character. So the next thing I wanted to ask you, I mean, this opens up a whole can of worms, is Bell's palsy. What is that? A peripheral neuropathy?
Okay, so the Bell's palsy is a peripheral nerve problem.
Right.
It the important thing. So Bell's palsy, Dr. Bell described it, of course.
Yes, of course.
I always joke that that diseases named with an eponym usually have a more protracted course, because it meant that you lived long enough to see the professor.
Right.
In rounds.
Yes.
The next day.
Yes. That's really true.
So this is a problem with the motor nerve involving the face.
Right.
And it usually has a rapid onset, evolves within a matter of minutes to hours, may be preceded by some pain in the ear, interest, maybe a different metallic taste in the mouth. And then suddenly you realize my face is drooping.
Indeed. And it is devastating to the otherwise healthy individual to have a drooping face all of a sudden.
And, certainly you go to the emergency room, you get evaluated. The pattern is typically fairly diagnostic. You will get imaged in the United States. Usually CT because it's quick in the ER. MRI, little not as commonly used in the initial steps because it takes a lot longer. Probably in follow-up you'll get it. Treatments. Unfortunately.
That's why I was asking the question. There isn't much.
There's not much. Do we use steroids? Part of your weakness will be an inability to close your eye.
Yes.
So corneal protection is key.
Yeah, that's eye protection, like
eye
a
protection,
patch or
a patch typically.
Yeah.
While you sleep. The peripheral nerve, and we presume the cause of this is a viral infection of the nerve, and it's an isolated viral infection.
Right.
The nerve will rewire. It will regrow. Unfortunately, nerve growth is maybe less than half an inch a month.
But it does happen. So
it can regrow.
Yes.
You can eventually have almost full recovery. The only time a neurologist might figure out that there was a Bell's palsy is that sometimes the rewiring that happens from the face, the fibers that go to the eye get confused with the lip fibers. So when you see the person after a Bell's palsy, when they smile, you notice their eye closes.
Well, I never noticed that, but that's really something.
It's called synkinesis.
A neurologist would notice, of course.
Neurologists have all these party tricks where we, look at patients and people walking around and we try to diagnose them.
Fascinating stuff. Fascinating. For our viewers, I'm sure you're intrigued by this whole story because we in medicine actually are not really totally tuned into what the neurologists' party tricks are all about, but we hear about them in clinical summaries.
We watch people.
Right.
Two neurologists sitting on a park bench are watching people and saying, well, what do you think? What's going on there?
Okay, so let's segue. We mentioned that Bell's palsy is probably a virus, but what about herpes or zoster? And that's amazing. And I'm going to tell you why our listeners would be interested in that, because intractable pain is usually what starts out as herpes zoster, better known as shingles. And we're going to refer to it as shingles. Intractable pain for a while, and the doctor has worked on the patient and tried to figure out why they have pain, say on one side of their body, maybe one rib or two ribs. What's that all about?
I think that any discussion of shingles has to really begin with an appeal that shingles vaccine is out there.
Yes, good point. Shingles vaccine, and that's quite a safe vaccine.
Shingles is a viral infection,
right, of
the nerve cell body that lies dormant. It has shingles infections have a very prominent place in neuroanatomy. The dermatome chart, that chart of where what nerves of the spine innervate the skin, was drawn up from postmortems of people with shingles.
Yes. And I didn't know that. That's very interesting. And it's only one half of the body for all of you viewers. One part, which we call, as Dr. Dane mentioned, a dermatome. It's like a map.
So shingles will lie there. And then as we get older, sometimes not even so old, a little immunosuppression, a little illness, or even nothing, and it pops out.
Yeah.
Very painful. And we have a vaccine now for it.
Yes. Now, a question I'm always asked, and I'm sure our listeners and viewers are going to ask, is shingles the result of stress?
Stress is a big word. I mean, there's physiological stress,
Yeah.
there's mental stress, and how do you do a controlled study of stress?
Yes. It's very difficult. Very difficult.
We're going to take people, and we're going to take half the people. Half the people get ice cream. The other half get a stressful life situation.
Yes.
I mean, what's in it for the people who get the stressful life situation? Everyone else is getting ice cream. Okay?
Right.
So, is it a result of stress and life stress? I don't know. Okay?
Right.
But other physiologic stresses can trigger shingles, right?
Right.
We've seen it in people who have generally debilitated immune systems.
Exactly.
From malignancies, from medicate or suppressed through medications or pharmacologically suppressed. So the real thing is isolated pain syndrome that follows a pattern of nerve root innervation, and your x-rays are normal. Start thinking this is the beginning of a shingles attack.
Right. And the fact that you mentioned there's a vaccine is terrific. And I'd forgotten that, and that will protect you.
I'm actually in the middle of my series. It's 2 injections, taken several months apart.
Yep. And very safe. Very good. And now the last part of our discussion, well, I wanted to talk about treatment, and we've already lighted on treatment. We've landed on that, but you do a lot of motor vehicle accident stuff where peripheral neuropathy is the major result of, say, having a whiplash injury or.
I mean, it's more nerve root issue. Those are more nerve root issues.
But they result in sciatica.
They result in sciatica or radiculopathies.
Right. Radiculopathy being defining the term for our
being
viewers.
A pain that travels through a limb from a central point.
Right.
Like the radius of a circle.
Oh,
That's the root of a radiculopathy. So, treatments are essentially in the absent, first question, can we modulate that nerve? Nerve modulation for pain management may involve, first anti-inflammatories, non-aspirin containing analgesics, the non-steroidals.
Right. Non-steroidals are drugs like ibuprofen. I'll just name a few. Celecoxib. Advil is a non-steroidal. That means they're not steroids, but they have an anti-inflammatory effect.
Now, pain management physicians now basically administer steroids under x-ray guidance to nerve roots through epidural injections given near a nerve root zone, the foramen. May be more effective in the lower back than in the neck. But certainly, this entire field of pain management has evolved to, if they can see it on an x-ray.
Right. Yes, they can block
They can block it.
Right.
They can block the facet joints of the spine. They can block the individual nerve roots. Basically, these are not just therapeutic treatments, they're also diagnostic to a certain extent. If you walk into a room and the lights are flickering, you're going to walk over to the light switch and say, let's see if it turns it off. Let's see if it turns it on. And so pain management doctors will use these blocks not just as a therapy, but also as a diagnostic tool.
Good. Great. Well, and these drugs are somewhat effective for the most part. I mean, we have, and I want to make the distinction for all of the viewers and listeners regarding peripheral neuropathy, which is being seen in many of the diseases that both of us take care of, but also not a part of chronic fatigue syndrome or a condition called fibromyalgia, which are 2 pain syndromes, but not peripheral neuropathies.
That's absolutely right.
Is there anything that you would like to summarize with?
at this point, when you have numbness, pay attention to the pattern of numbness. If you go to your medical provider, they're going to ask you about it.
Mm-hmm.
They're going to ask you about what provokes it.
Mm-hmm.
They're going to ask you about its quality. They're going to ask you about its location. When you're sitting in the room before they walk in, take off your shoes and socks. It will remind them.
Yes, that's a good point.
And vaccinate early and often.
Great. Very good point. To keep yourself free of conditions like herpes zoster, the cause of shingles,
Yes.
for example. All right. Well, Dr. Dane, we really learned a lot during this particular segment, and I hope all of you out there now know more than you ever thought you could know about peripheral neuropathies. I know I have many patients who are going to be enlightened by this whole discussion, and I'm sure that those of you who have never thought of peripheral neuropathies will now begin to appreciate the depth of the problem, but also the fact that we have so many newer agents to treat these neuropathies with. And thank you for coming. We really appreciate it. I want to have to do a shout out to the New Jersey Medical History Society. Both of us are members.
That's right.
And I always like to have a little bit of history as part of our show, so that we can see that a lot of these things go back hundreds of years,
right,
to before we had anesthesia and all, and we've come such a long way exponentially in the last few centuries.
Yes.
So thanks for coming again.
You're very welcome.
Thank you
very much.
Thank you for joining us on Health Frontiers. I hope today's episode provided valuable insights into your well-being. Remember, this podcast is not a substitute for professional medical advice, but a source of knowledge and guidance. If you have any questions or topics you'd like us to cover, please reach out. Make sure to like, subscribe, and visit our website at www.healthfrontierspod.com. Join us next time as we continue our quest to uncover the latest in health and wellness. Stay healthy and empowered. Until next time, I'm Dr. Bob.